Okay, good afternoon to everybody and welcome to the Nottinghamshire Healthcare Board meeting. We are having this meeting virtually, as many meetings are at the moment. So my name is Paul Devlin. I'm the Trust Chair, and I'd like to welcome board colleagues to this meeting, but also to put out a welcome to any of our staff who are able to be watching us via an internal live stream. We're testing that technology today and very much hopeful that we'll be able to go to something similar for the general public from our next board meeting on. So just a couple of things about the housekeeping for the way that we're going to work today. My colleagues of executive directors and non-executive directors are all muted, but as and when they wish to comment will be invited in to speak and present. So we will make sure that any comments or questions are presented fully in the public board itself. I've invited colleagues to do our best not to let acronyms go by without introducing them fully. I know that it's one of those things that as boards we can sometimes get caught up in language that we're very familiar with, but not necessarily is the case for others. And I also wanted to say that this is a somewhat streamlined board agenda, which is in line with the national instruction that we've had, which has been to enable the fullest focus on COVID-19. Our other governance responsibilities remain, and I'm grateful to Craig Sharples, Becky Cassidy and Grace Rao and other colleagues for swiftly enabling us to transform some of our governance structures and ways of working. This has included instigating the potential to use emergency powers, such as reduced number of board members able to take decisions and stripped back board committees. We've been using those as sparingly as we possibly can. So I'm going to take us then to our agenda proper. And first of all, just to ask Craig to confirm any apologies for absence, please, Craig.
Sorry, there's no apologies for absence, Chair.
Thanks very much, Craig. In terms of declarations of interest, do executives or non-executives have any declarations to declare in relation to items in the public agenda, please? If you can indicate by just on the chat bar, I will then be able to put audio to that if anybody's got any to indicate. Nobody's identifying them there. Thank you. In which case, if we could go to the minutes of our last meeting, which was held on the 7th of April, and ask first of all if we can take these as an accurate record, please. Again, could colleagues indicate if you agree or have anything you want to check out on for accuracy, please? Thanks. If I could just a few more agrees, if that's where people are going. Just checking, Alison, that have you got a query there?
No, sorry, I was saying no, I didn't have any points of accuracy.
Thank you. I'll try and be really specific with exactly what I'm asking you, so I'm not offering you two different answers there. Thank you. We'll take those as accurate. And if we could go then to the action log and any matters arising, please. It's down as having been completed. And again, if I could just get an indication from colleagues if you've got if you agree or if you agree with the action log as is, please. Thank you. So I'm going to move us on just before I hand over to John Bruin for the Chief Executive's environmental scan, which is very much a COVID scan, I just wanted to say a few words as chair. Again, in a less stripped back board, I would be wanting to feed in some reflections on what I've been up to during the last few weeks since the board a month ago. But first of all, what I wanted to do was just to put out there a very heartfelt thank you to all of our staff and volunteers, and just to really reflect and thank you for the genuinely heroic efforts you've put in to transform services, to keep on protecting those who need our services and supporting one another in these strange and dangerous times. And myself, and I know colleagues around the board table, I'm personally so proud of and humbled by your skills, compassion and commitment, and the work that you've been putting in, especially over this last couple of months. Like the other non-executive directors, I'm primarily working from home or occasionally coming into Trust headquarters like today, because I need the Wi-Fi strength in terms of the video technology. And despite our desire to get out and see people and services, we know as non-executive directors that a key job for us is to keep ourselves safe and to keep others safe by keeping out of the way. And it would be inappropriate for us to be going into our services at this time. And I know all of us have had to cancel visits that we had got planned, that were in the calendar, but they've all been logged and they will get reinstated. And I very much look forward to getting out there and meeting more staff and volunteers within our services, as well as those who are using our services. And I usually update on some of the activity I've been involved in on the Trust's behalf. And unsurprisingly, it's been very COVID-19 focused. So obviously one-to-one catch-ups regularly with John as Chief Executive and catch-ups with other executive team members as needed. I've had weekly calls with all of the non-executive directors and executive colleagues so that the non-execs are all up to speed. And I've done 2 update videos for our governors and staff, and also a video message for our volunteers. And John and I recently did our first pod chat where we were able to have a conversation about starting to think about what comes after COVID-19. And I've also been involved at a regional level and national level with meetings with other chairs from other trusts, both nationally and regionally, and also been on a call with non-executive director colleagues across the country on our responsibility in understanding and responding to the disproportionate impact of COVID-19 on Black and minority ethnic people, and particularly on our BME staff. And obviously I've been feeding learning from all of those meetings into the Trust. I know John will say more about some of the operational detail on those, but I just wanted to give you a flavour of some of the things that have been helping keep me busy over the last 4 weeks or so. So at that point, I'm going to hand across to John and ask you, John, to take us through your environmental scan with its COVID-19 focus. Thank you.
Hi, afternoon everybody. Just checking that I don't sound like Donald Duck, much to the mirth of the executive team. My feed sometimes translates me into Donald Duck, but if I don't get lots of comments in the comments box, I'll presume that you can all hear me as normal. The paper is there, take it as read. I'll run through just a couple of things to highlight, then happy to take questions and comments. As ever, the highlights from the national picture from the Care Quality Commission, it relates our current rating. Just to note, we've received the latest draft report on an inspection of the learning disability wards at Ramson that occurred in March, and we've actually just found out today that it's due to be published on the 8th of May, and there are some quite positive bits of feedback from the CQC, which is good to get. We've also been put on notice that although currently the CQC have suspended their comprehensive inspections, there are still some trusts that they've got concerns about that they will be doing a virtual inspection using data that we send in all the time, and we will expect to get notification of that at some point in the future. NHS improvement, England combined. I've just put a small piece in there that essentially they are in a what's called a level 4 command and control situation at the moment with regard to COVID, and they coordinate a lot of the national instruction through the region, and by and large they've been very supportive in helping support providers in terms of for example accessing PPE and coordinating testing. Obviously a lot of the focus has been on acute hospitals, but many of our services have had a very significant part to play in enabling that across the system, and we are forecasting that the implications with regard to mental health services is coming down the line anytime soon, and we're planning and preparing for that. I put a small piece in with regard to the East Midlands Alliance, so which is the 5 mental health provider trusts in the East Midlands plus St Andrews, and we have regular sessions with the chief executives and increasingly other executive directors. So that, for example, the strategy directors of strategy and partnership also meet on a regular basis, and we're starting to explore how we can learn from it, share learning, learn from each other, develop service improvement methodology across the East Midlands region, and there's some good examples also, some mutual support during the COVID period. There's a piece there on page 3 which is headed trust-wide, and that just gives you a sense of some of the day-to-day business that the trust is involved in terms of situational reporting, in terms of gold command reporting, both within the trust, within the system, regionally and nationally, and many of the executives are involved in a whole number of different calls. I think probably the important thing to say is that the frequency of those is starting to reduce now, so many of them have been daily. We're reducing our internal gold frequency of that, and some of the system calls are also less frequent now, as it's clear that we are past the peak and we need to be starting to think about next level. I've summarised some of the key issues relating to personal protective equipment and staff testing, which I'm sure many people are familiar with. It's a national issue. In summary, with regard to PPE, I would say that we're at steady state now, but we're still functioning on what's referred to as a just-in-time stock. So we haven't got any stock that's going to last any length of time, and we are dependent on regular deliveries to keep us topped up. Although overall the system and the process has improved quite considerably, and we're not reporting any lack of PPE in any of our sites across the trust. With regard to testing, that's been a fairly complicated endeavour to set up both nationally, regionally and locally from what essentially was a standing start. As you can see, when I wrote this, we were a long way off the national target of 100,000 a day. But importantly, I think the ambition now is it's not just about the volume, but it's about targeting. the testing, and there's something around testing, tracking and chasing to make sure that within different localities, when new cases arise, there's an immediate response to contain it. So that we're going to see a sort of change in direction of the testing, I think, in coming weeks. I wanted to spend just a little bit of time following on from what Paul was saying with regard to our operational services and our support services within the organisation. Over the last couple of weeks, I've had the opportunity to start to visit some of our sites as well. And I just wanted to reflect on across the whole of the organisation, the amazing resilience and fortitude shown by staff. There's a real can-do attitude, there's a real positivity and a complete focus on supporting patients and caring for them as best we can and supporting each other. And I've just identified a few wards there and areas that have had some quite significant numbers of COVID positive patients to care for and manage, and without exception, our staff have just been phenomenal. I wanted to make that clear for the board today. But equally, it's been a team effort, and this is it goes to the heart of the values that. The culture and values work that we've been doing, that the teams there in terms of what we've done in digital technology, procurement, estates, pharmacy, comms, admin, workforce has been absolutely staggering. The amount of transformational work, the mutual support, the working together with operational services has really been something to behold. And it's really pleasing to be in a position to report that. There's just a couple of things to mention because we're in a fairly fast-moving environment that have occurred since I got this report in on time. There was the next letter from the Chief Executive of the NHS, Simon Stevens, who first triggered the level 4 critical incident. His latest letter arrived last week and starts to set out the next steps. And again, he's keen to emphasise that we are, despite the fact that we're past the peak, we are still at level 4. In command and control. So essentially instruction is coming down from the national and regional teams, but we're already starting to think about how we restart services that may have been stopped. So that particularly pertains to acute trusts, but also planning our recovery phase in terms of thinking about things that we've started that we'd like to continue and things that we've stopped that we want to keep stopped. And so there's an important piece of work for us all that we're all working with to describe that across the trust. And then last two things, Paul mentioned the letter that we've written to our BME staff towards the end of last week, supported by the network. It's a really important endeavour, and it's really important given the emergent risks that this staff and patient group have experienced with relation to COVID, that organisationally we fully support all our staff as best we can. And there's a more detailed piece of work with regard to making sure that we've got individualised, personalised risk assessments for all our staff that are vulnerable and at risk. And I did a pod chat with the co-chair of the BME network today, Angela Walker, to discuss some of that in a bit more detail, and that was a really positive piece. And then finally, to highlight particularly where I've visited over the last couple of weeks, the wards at Millbrook, all the wards at Lingsbar Hospital, and I probably think about 8 wards at Highbury and visit to the crisis team, again reflecting the fantastic performance and passion and commitment that all our staff are committing to getting us through the crisis. Sorry, that was a bit of a long-winded run through, but hopefully just gives you a sense of some of the work that we've all been doing.
Great, thank you for that, John. And I think it does give a sense of the scale of work that has been going on over the last few weeks. I've not got any indications of comments and questions from others, but I wondered if you might just say a little bit about what we're starting to think about in terms of the demand on services as we go past the peak, because I think there's a narrative out there that obviously in terms of acute care, we're hoping that we have passed peaks, but I'm particularly conscious that in terms of demand on mental health services, the mental health of the nation, let alone of those people who currently use and have previously used our services, is going to be seriously affected by many elements of COVID. And I know it's early days at the moment for thinking about that, but I wondered if you could just flag some of the elements that you think might be in there.
Yeah, thanks. It was interesting. There was again a national letter from the Department of Health the week before last, basically instructing the restart, and mental health and community providers were keen to emphasise that we hadn't actually stopped things. We were doing things in perhaps different ways, but and it caused a bit of irritation because there was a sense that we were all sort of sat back waiting for it to pass. So, for example, there has been a very significant reduction in referrals into mental health and community services, but an awful lot of work has continued. There's been an opportunity to catch up on some of the longer standing waiting lists. Many patients who are presenting are complex and perhaps more unwell, so need more time to stabilise. And Claire Murdoch, who's the National Clinical Director for Mental Health, was before the Health Select Committee at the end of last week and put the case for mental health and the Disability Trust very strongly that it's all very well telling us to restart, but we actually haven't stopped. There's a lot of work going on nationally, starting to think about what's called modelling in terms of predicting what the demand is going to be for mental health and disability services. But one of the challenges for that is that we're to use the common term, we are in unprecedented times, and there isn't really an awful lot to model what some of this forecast demand might be. But you're right, there are two main areas of mental health. One will be the demand that has relatively reduced because we know that referrals, for example, into children and young people's services, into psychological therapy services, in particular, has reduced quite significantly, and that hasn't gone away. So that will be out there, probably on its way back in. And the other big area relates to the impact of the COVID life that we've all been living, that's having on our mental health and well-being, and that's probably a bigger unknown, really. What impact is that going to have on levels of anxiety and depression and other manageable mental health conditions? So it's probably a bit too early to say what the quantum of that is, but we do need to start thinking about how we will be able to respond to it in the coming weeks and months.
Thanks very much for that, John. And I think that's a really thorough presentation of both the situation and also putting down some markers for what may be coming next. So I've not got anybody else indicating to comment, so could I just ask colleagues to indicate if they're content to receive John's report there, please? Thank you. That's great. Steve, just checking that your C is a content rather than a comment. Thank you. So in which case, I'm going to move us on to item 59, which is the people and culture update, again with a particular focus through the COVID lens, and ask Claire to introduce yourself and the paper, please, Claire.
Hi, thanks, Paul. So good afternoon, everybody. I'm Claire Teeney. I'm the Exec Director of People and Culture at the Trust. In terms of the report here today at the board, I was keen that actually we gave the board the opportunity to see the amount of work that's taken place with regards to supporting our workforce during this time, and also to reflect some of the considerable changes and agility that our colleagues have made over the last few weeks in order to enable us to deliver the services that we have needed to continue to deliver for our patients and service users. It's only been a few weeks, but I think the paper does reflect the size and scale of some of the things that we've needed to do. And I thought that it was important to capture that, because as time moves on, there's a sense of we will move through this phase into a different one, and there'll be a whole host of other asks and things that we need to do to support our workforce moving forward. Overall, the paper does give some indication of the levels of staff that we've had in self-isolation and off during this pandemic. At the time of writing the paper, that was 701. At its highest, it was over 800 at any one day in any given time. Today, that figure has gone down considerably. It's now down to 515. What that means yet, we're not entirely sure, but I think some of it has been, as we've moved through this, people have been clearer about the reasons for isolation and also the symptoms that also go with COVID as well. What I would say about that is that whilst the figure is at 515 and there's been new staff in that cycle, we have had some staff and colleagues that have been off quite rightly and consistently throughout, and they are people, for example, who've needed to shield themselves because they're particularly vulnerable and susceptible to detrimental impacts on their health and well-being during this time. John touched on his report, some of the work that's been underway around staff testing. That's been an ever-changing situation and one that does continue to evolve. We have been able to offer all of our staff that meet the criteria for testing, and that's been a criteria around them being symptomatic or people in their household being symptomatic. We have been able to offer them tests, and they have been being worked through. You'll have seen on the news that actually all NHS workers are now being offered tests. However, we are still having difficulty in being able to access some of those for our staff, and we do hope that that situation will continue to get better over the next few days. All the indicators are that it will, but we are still experiencing a few challenges at this moment in time. I'd like to express particular thanks to our staff side colleagues who've worked really hard with us over the last few weeks to make short-term interim changes to a number of our policies and procedures to enable us to work things through and support our staff, and I'm really grateful to all of their input and support that they've given in terms of that. In terms of training, you'll see that we've paused some things and continued with others, and we've ran other training opportunities in different ways to ensure that we can socially distance in line with the government guidelines, and we will be revisiting over the next few weeks our training offer, and we'll hopefully be bringing a number of things back online that were paused temporarily. Some of the significant things that we've been able to introduce, the report makes reference to the fact that Tracy Orlandi has joined us as the Health and Wellbeing Lead. Tracy joined in the middle of April and has already been able to set up a number of things to support staff health and wellbeing. One of the things that was asked for when we did the consultation exercise with staff about what a good health and wellbeing offer would look like was that we had a single point of access so that people could telephone somebody to ask about what health and wellbeing support was on offer and or email them. And that single point of access in terms of that wellbeing service has now gone live and is available to our staff. So that's been really, really good progress. And Tracy and her newly formed team have also done quite a lot of work with our shielded members of staff. So everybody that is shielded within the organisation has received a supportive telephone call and knows how to contact that particular team, which has been really important. John also touched on the letter that we've done to our BME members of staff. That's really important. It's important that our BME colleagues feel supported. It's important that all of our staff feel supported. And whilst we have done a number of risk assessments across the organisation, we are revisiting our whole risk assessment process, and we'll be doing some further work on that, which starts this week, to ensure that we put a level of independence into those risk assessments and that actually we do revisit some of the adjustments that we may need to make and can make to ensure that our staff can continue to work safely within the organisation. There's been some hugely positive things that have come out of this time as well. We've been able to adjust a number of our processes. For example, the streamlining work that we've done around recruitment has meant that we've been able to mobilise people through to be able to work in the organisation much faster than we ever did. And they're some of the things that we will harness and continue to work on going forward. Most of the detail, I think, is captured in the report, so I won't draw out any of the other points anymore. But I hope that it does reflect some of the things that have happened, and also, again, just reflects just how brilliantly cooperative all of our staff have been in terms of adjusting to some really different ways of working during this time. That's all from me in terms of the report. Thanks, Paul.
That's great. Thanks, Claire. I've got a few questions that have been flagged. So and again, if people could just introduce yourself before you're asking your question or giving your comment. Steve, if I could go to you first, please.
Thank you, Paul. I'm Steve Banks. I'm a non-executive director with the Trust. Claire, thank you for the update, and it's encouraging to see that the numbers of people returning to work will give us a bit of a boost over the coming weeks. But of course, we don't know how trends are going to go in the future. You mentioned the staff testing. Do we have any insight into how long it's taking to get results back? And do we have any control over that so that we can ensure that staff are able to get back to work promptly, as that's one of the reasons that we might want testing carried out?
Thanks, Steve. So one of the things that we've done to support staff testing is that we set up an internal team to be able to support staff through the testing process. So staff can register directly to access a test, and of course, you know, if that's the way that they want to do it, that's absolutely fine. What we have been doing is, where we've known from our data and intelligence that staff are isolating for a particular reason or are off, then we have been proactively calling them to support them through the testing process. And we have encouraged staff through our internal communications to register with us for a test. And that way, it enables us to have oversight of who's then gone through a testing process. The situation in terms of timescales has been ever changing. So 2 weeks ago, that was fairly swift, and people were receiving slots for testing the following day, albeit there was some challenges about tests couldn't be accessed across the whole county, so there were some geographical challenges, but they could be accessed in a timely way, and the results were coming back in generally in 24 hours, and we were doing follow-up calls with staff to assure ourselves that they'd been to their slot, they'd had their test, and we got some sense of where things were at. Where we're at now is that we are having some challenges in terms of some delays about people being given testing slots, and also where some of those staff are being offered those slots is really quite obscure, so not even regionally but nationally. And I think that's some of the problems with the national system, and that we are now experiencing a couple of delays, so it can be 24 hours in terms of a result. We've had some recently that have been 72. I'm hopeful that, as with all systems, once things get a bit more embedded, that they will settle down a bit more. What I would just say finally, having the internal team to support it is a good lesson learned. Having that support team that have supported staff through the process, and somewhere for our staff to contact with queries. We've had a real swell of really good feedback around staff feeling that that's really been really valuable to them.
Yeah. Okay. Thank you.
Thanks very much. I'm going to invite Alison in again. If you just introduce yourself, Alison.
Yes. Hi, I'm Alison Rose Query. I'm a non-exec director of the Trust. Hi, Claire. Thanks for your report. Just a couple of quick questions from me. One is that we are, well, nationally, I think we're anticipating that our spike in terms of mental health and community services won't come until after the physical side of COVID's been dealt with. So we could expect quite a significant surge in terms of our service requirement in the coming months. And as a result of that, in terms of staffing, have we enabled and facilitated staff to have time off and take their annual leave, particularly as we're starting to come out of this a bit now? Now maybe is the time to have annual leave. And also from the helplines that we've set up and the communications we've had with staff, is there any indication that there is heightened anxiety and stress that is being shown by our staff that may manifest itself further down the line?
Thanks, Alison. So in response to those queries, in terms of the kind of the staffing that we might need further down the line, and in terms of annual leave, we have at the start of this a few weeks ago, people would have had potentially some annual leave that would have been at the back end of last year's leave year. So quite often people save a week just in case, and some staff did cancel that week and support us to kind of deliver what we needed to deliver at that time, and we've given people assurances about being able to take that. As we've moved through the last couple of weeks, we've found that there's been less need for staff to cancel time off, and indeed we've been encouraging people to continue with time off. So we are being quite proactive about ensuring people are taking rest as is appropriate, and we've had enough staff generally within our services to enable people to be off at this time, and we'll continue to do that. A good example is the bank holiday. So if I take the Easter bank holiday, we did staff up a little bit more and people were accredited with their bank holidays. For this bank holiday this week, we are running it as much as possible as a bank holiday and a bank holiday weekend. So the message is, if you can be off, please be off. And that's how we're trying to run things in anticipation of managing that. There's not been any increase specifically in terms of staff indicating that they're experiencing any more higher levels of emotional distress. There are, of course, a few exceptions to that, and that's been particularly around some of the staff that are in the more vulnerable groups. So for our pregnant members of staff, for example, they'd got some particular anxieties related to this time, these circumstances, and we've been trying to work those through. Tracy and the wellbeing team are, though, thinking about our wellbeing offer and thinking about the sorts of interventions and support that we are likely to need in place going forward, not just for our staff within the organisation, but more widely across the health and care system. And just on that note, we are going to be supporting, for example, our staff in the care homes within the system, that's where we have picked up the need to put in some additional support at this particular time.
Alison, are you happy with that, or do you need to come back?
Sorry, I did respond, but I was on mute. Thank you very much, Claire. That's fine. Thank you very much.
Great. I've got Stephen and then Steve. So Stephen, if you could introduce yourself, please.
Yes, Stephen Jackson, Non-Executive Director. Good afternoon, everyone. Claire, I just want to say, first of all, what a good report, clear, concise. So it was really helpful and easy to absorb. My question just builds, I think, on what Steve was saying. The absolute quantum number of our staff having been tested seems to be relatively small out of our overall workforce, and I wondered if you got anything to say about that. Is it something to do with the ramping up, or is there something else at play there?
Hi Steve, thanks for that. The numbers that we've put through for testing so far are small because up until sort of the back end of last week, the criteria to be eligible for a test was quite tight. So as a member of staff, you had to be sort of symptomatic in day 0 to 5 of having those symptoms, ideally on sort of day 3, to be eligible to meet a test. And of people that were off, not everyone was in that particular criteria. What I can assure you of is that for those people that were self-isolating that met that criteria at that time, we were very clear that we were able to offer everybody access to a test. One of the issues that we've got now that tests are available for all NHS staff is that we are struggling to be able to access being able to put that volume of people through. There's a national issue in terms of availability of places for people to access that test, and also lab facilities. As I said before, I'm hopeful that will start to settle down.
Thank you, Claire.
Thanks, Claire. I've got Steve and then Carolyn, and then I think I'll see if we can draw this together. So Steve, over to you again, and then we'll hear from Carolyn after Claire's responded.
Thank you, Paul. Steve Banks again, Non-Executive Director. First, a comment before question. The amount that's being done and is reflected in the report kind of echoes John's introductory comments of just how fantastic people have been and how much effort has been made at all levels, and clearly around engaging people, that's exactly the same. A lot of the paper focuses on quite rightly on the need that we've had to ensure people are well informed and supported, and helplines. I had a question on how you feel, Claire, our channels are open to listen to people as much as we've had before, because that's been hugely important to us. I know there's been podcast QA sessions, but in terms of people raising concerns or wanting to get feedback back, how do you feel that compares now? And what are you thinking for the next kind of month or two as we move into the next phase, please?
Thanks, Steve. So my sort of reflections on this are that I think there's been much more transparency across the organisation about the things that are going on and the things that we are doing. Some of that is that then means that where people are well informed, it means that they are less likely to speculate about why something might be. So I think for us, having much more upstream, upfront, regular communications is something that's worked well, and we need to continue to do that. In terms of listening, I do think that we've opened up a number of channels, and I think some of our IT and social media routes have also enabled people to be able to get in touch, comment and do things in different ways, and I think we've been much more responsive. So one of our issues wasn't necessarily not listening, but it was the time taken to sometimes respond. As with all these things, are there still things for us to do and get better at? Of course there are. Our networks, for example, the BME staff network has regrouped. So they had a meeting this week, and I think engaging people to think about how we continue to do this better is also something that we'll continue to work on. I should also say that our Connecting Notts healthcare programme, which we'd started, and as part of the Connecting Notts HC piece, we'd got sessions lined up at Trent Vineyard. We're hoping to go live with those again this month, albeit done in some slightly different ways, and it'll be through those channels that we'll solicit feedback from people about how we can continue to improve the speak up and listening agenda.
Thank you, Claire. Paul, if you don't mind, as specific. So one of the things I'm wondering about, this doesn't necessarily need an answer right now, is John's mentioned before about how it's been possible to empower people like never before. So we've got that going on one hand. Equally, words like level 4 command and control are around the place, which would give a good opportunity for those that want to slip back into unhelpful habits, perhaps, might feel they've got the license to do that. And I think it's just something I'd want us to be aware of and actively planning if we can, please.
Do you want to reflect anything on that one, Claire, or is that one for us just to note? I think it's a good reflection, Steve. But Claire.
So I say I think it's a really good point. One of the things that I would also say is that I think the point about command and control as well is that some of that has that approach we've eased off as we've been able to get some of the systems and processes in place, so that, for example, the rollout of PPE is easier. People know how to access staff tests, all of those sorts of things. With all these things, it's not necessarily about the system that you have, it's the behaviours and the values that underpin how that works. And I think getting back to paying attention to our co-produced values and how they are embedded in teams, and that being a way of working for our organisation, is absolutely something that we need to prioritise and focus on over the coming months.
Yeah, lovely. Thank you, Claire.
Thanks. And Caroline, I know you're waiting, but I'm going to bring Itai in first, because I think, Itai, you'd got a comment to make in response to one of the previous pieces.
Yes, I was just going to add to what Claire's already said about our ability to listen as an organisation recently. We also created some other platforms through Microsoft Teams, such as the Medical Doctors Forum, where people have been able to contribute ideas, and has brought a sense of a unity in terms of how to deal with this crisis collectively. So that's probably been a positive from this crisis situation.
Many thanks, Itai. And I'm going to go to Carolyn, and then I think we'll wrap this up after Carolyn and any response. So over to you, Carolyn, please.
Thanks, Paul. Carolyn White, Non-Exec Director. Claire, just a very brief question. In your report, you refer to the fact that we have been continuing to offer placements to students. I'm assuming they're student nurses, but I guess they could be students of any discipline. I just wondered how we're being able to continue to do that and ensure that their placements were both appropriate and safe. Hi,
Carolyn, thanks. Yes, so that has been around around student nurses predominantly, and I suppose it's in the same way that we do in normal times, but with a bit more wraparound really. So it's about ensuring that they're placed in areas where we've got the appropriate support and supervision. We've got the right links with the universities to ensure that we've got good governance around that, and we have retained a sort of corporate and central team to ensure that there's the right balances and checks, and also sort of pastoral care that goes with that placement opportunity. We've been very conscious not to put anybody that's with us at this time, either in a substantive role, a student role, people that are apprentices, in any area where it's going to cause them any undue anxiety or risk unnecessarily. So we've put some quite good governance around it.
Thank you.
Great. Thanks very much. So, colleagues, we were asked to note the report. I think we've given it some exploration as well, and I certainly support the comments that have been made by colleagues about the amount of work this represents by a substantial group of our kind of corporate teams, and pass on thanks to those teams. So let's receive that report and move on then, if we can, to the integrated performance report. And Simon, if you'd like to introduce yourself, please.
Thanks, Paul. Afternoon, everyone. I'm Simon Crowther. I'm the Executive Director of Finance, but I also have responsibility for performance as well. I'm going to take the paper as read. Rather than go around each of my executive colleagues, I just suggest they use the chat bar as we have been doing for comments, Paul. So I'll just introduce changes we've made to this report, give a brief overview, and then open it for comments and questions. Board members will probably know it's a reduced report, and what we've tried to do as a team is focus on the key issues we really want to bring to the board's attention. So it's in the usual format. It does move through each of our areas in terms of operations, quality, workforce, and then into the stewardship and finance. As I mentioned, we've really tried to focus on what exceptions we need to bring to the board, and hopefully colleagues can see that the report is a bit more succinct. It's based on the latest information and finishes and squares off last financial year, and we'll continue to develop this. So I still think it does need further refinement as we move through the recovery that John talked about earlier. I think this needs to continually change, and we need to continually refine it as well. But also, just for board members' assurance, we still do have oversight of the full IPR. That's overseen by us as an exec team and around the organisation, and is available for board members should they want to see the usual full report. And I'll probably leave it there if I can, and just note, if I can, a comment on the finance section at the end of this item, Paul, please.
Great, thank you. Julie A, you wanted to make a comment, so introduce yourself, please.
Hello, I'm Julie Atfield, Director of Mental Health. I just wanted to add a couple of supplementary comments on the local mental health performance. That was in relation to the meeting of all the mental health plan targets, the National Mental Health Plan targets. That's a considerable achievement from the perspective of our services, and just wanted to acknowledge the work of colleagues. The other point that I would like to raise is in relation to the acute bed usage. So in the report, it's framed around the out of area placement days, and it's also framed in relation to the use of subcontract beds. Now, colleagues will know we had a very, I think, realistic plan to reduce the use of subcontract beds. However, I did just want to flag that over the very recent weeks, in fact since the last board meeting, our use of inpatient beds has started to change. Our patients are much more acutely ill. We've seen a rise in admissions, and discharge is more difficult to effect. And we have seen an increase in the use of PQ beds, that's psychiatric intensive care unit beds. So we have been working through some projections, and the plan to reduce the subcontract beds in the way that we had planned is not really going to come to fruition, unfortunately, and that is entirely, we believe, related to the changes in the use of beds and COVID. The additional complicating factor was, of course, we were due to give notice on some, and we had given notice on some subcontracts in May, but now we are also obliged to cohort patients for isolation and so forth. So it makes our use of beds in the trust much less flexible than they had been. So I just wanted to flag that will change the plan that we did have, unfortunately.
Thanks, Julie. I'm just going to bring Simon back in before I go to other colleagues, but Simon first.
Thanks, Paul. Just to comment on what Julie's just said, and a conversation I had with Julie about one of the things I think we probably should do as an organisation is start to really understand and make sure we know the capacity impact of COVID. So we've talked a lot about the transformation of it, and I think we can talk a lot about some of the efficiency and productivities, but there is also going to be a kind of converse capacity impact, and not just in mental health services. And I think this is a good example of that. So I think as an exec team and as an organisation, we'll take forward something about making sure we do understand how our services are changing on the back of this, but particularly in terms of capacity into the system.
Thanks, that's helpful. I'm going to go to Alison for questions, please.
Yeah, thank you. Alison Rosequarry, non-exec. Thank you. It's probably for Julie, because, well, I've got a number of just points to and questions to ask on the performance report overall. But following on out of area placements, how many people are we actually talking about, Julie?
Out of area, it's a very small number. It can be probably up to about no more than 10 PICU patients at any one time, and considerably less than that most of the time. I just think it's worth clarifying as well, when I talk about the use of subcontract beds and the impact on that going forward, they will not be out of area. So as a consequence of the pressure, we believe it will still be completely managed within Nottinghamshire. The only exception to that may be female PQ beds, where we may not be able to have all of the capacity within Nottinghamshire, but we're hopeful that we will keep that down, and then that will reduce to virtually nothing.
Okay, thank you. That might be one for the future in terms of capacity planning, given what we think might happen going forward, either on a temporary basis or permanent basis. I've got a few questions on the actual performance report, if I may, so I'll ask them all in one go to save going back and forth, if that's all right, Paul.
Yes.
Great news on the IAPT waiting list. So that is a remarkable achievement in March, given that this is when the COVID started. So well done on that. The CAMS patients treated, the 18-week referral, that's gone up quite markedly in March, and I just wondered what the impact of that is in terms of young people and what they're going to be doing in the meantime, whether we've put anything in the interim before they actually manage to get assessed. So that's one question. The number of falls, self-harm incidents and medication issues is rising, or has risen, particularly the number of falls, which is concerning. It seems to be sort of up and down, but it's gone up quite markedly, and I just wondered what we are able to do about that. My other comment was the annual reviews. Now, I appreciate we're in a difficult situation at the moment, or have been for the past month or so, but it is a downward trajectory, which is starting to be worrying. So I wondered when we will get a plan in place to get that back on track again, because that obviously has a knock-on effect in terms of staff motivation and staff culture. So those, I'll restrict it to those.
Thanks. And my understanding was that the annual reviews was one of the instructions from the early phase, that they were things that should be put on hold. But I don't know, Simon, do you want to start and then steer back to involve Julie, or hand it straight across to Julie?
I'm happy to hand those across, Paul. I think they're all ops.
Okay, Julie.
So in relation to CAMS, we've moved capacity around to support the services that are most active at the moment. So you'll see later in the agenda, we've got a real breadth of CAMS services. And so we've been able to move some clinicians around to increase that response. However, some of the breaches do relate to patient choice as well. So there's a number of, there's an aspect of that. They have in recent months tried to make the front end of the services very different, to change the way that people can be assessed. So more telephone, more online, and more flexible appointments. So the service has done an awful lot, and they have moved capacity. We haven't been able to address all of the choice issues yet, and they do keep coming up. So I think that's actively managed. On the CPA reviews, that's part of our recovery and restoration plan. We are reviewing the direction in terms of the national guidance around CPA, and we think that whilst we have not been doing the formal reviews as they would have once been done, we are reviewing patients actively. And I think we will be looking at an alternative format of CPA review to implement, because of the social distancing and the other parameters that we've got around us. I think there will be a new norm, and we will have to lay that out quite specifically about what that looks like. But we're optimistic that that's a strong part of particularly our local mental health team recovery plan.
Great, thanks for that. And I think Claire, you were just going to just add in on that about staff annual reviews as well.
Yeah, thanks, Paul. I think that was one of the points that was made, and I think that it's fair to say that whilst we have put on hold some of the annual reviews that would have been undertaken during this time, I think we'd already acknowledged that it was an area in which we needed to focus on as an organisation, because that annual review stroke appraisal, if they're not happening, it can be a signal and an indicator around other things not happening as well. And picking up on Steve Banks's point earlier about listening, engagement, relationships and proper discussions within the workplace, then where we were and what we need to focus on going forward, it doesn't detract from that. We might have had a period of temporary cessation around doing some of the formal things. I don't think we should miss the point about we might have to do things differently, but ensuring that there is proper engagement in the workplace, appropriate and proper relationships with teams, and that line manager discussion is absolutely something that's going to be critical to us, and we will be getting back on track with some of that fairly quickly.
Great, thank you. And I did see some nods on my screen here from colleagues supporting that position. So I'm going to go back to Simon for a brief bit on finances. I know Stephen's got a comment, and then I think bring John in as to summarise this if there's not other comments. So Simon.
Thanks, Paul. So you'll just note, included in the IPR is our financial performance for the end of last financial year, 1920. And just to give a brief explanation, so we did achieve our plan in the end, which was a £400,000 surplus. Really good by the organisation, given some of the improvements and investments we made into staff wellbeing, particularly in quality. So to still use the monies wisely is a really good achievement. I just also want to explain, though, you'll see the numbers in terms of our final position have improved by 1.7 million, which was additional funding from the centre to recognise our achievements. And just to briefly explain that, so there is very little we can do with that in terms of spending that in 1920. It really just improves our bottom line. However, it is money for us in the bank, cash in the bank, which in the current financial year we can look at how we utilise that on capital, and we will be doing that.
Great, thank you for that. And I'd go to Stephen, and then I'd like to invite Trevor in as well, and then I'll go to John. So Stephen, please.
Stephen Jackson, non-executive director. Simon, congratulations to the whole team on delivering this set of results. Particularly our journey this year has not been straightforward. So to land with that result, I think is brilliant in the circumstances. So just congratulations to everyone, and to finish up with such a strong cash position as well. And perhaps most amazing of all in the current circumstances, to get all the capital expenditure out of the door is it feels like landing on a sixpence. So well done.
Right. Thanks very much for that. And Trevor, do you want to just add a comment in here at this point too?
Sure. Trevor Orman, non-exec director and chair of F&P. Really, I need to reiterate Stephen's comments. I think that the previous year was a tough year all round in terms of managing finances and managing the overall performance. And all credit to Simon and the team for getting that. And that's not just a one-off, that's continuous performance over a period of time. So I think it's a really tremendous result, and congratulations to all of them.
Thanks, and I'm seeing that others are supporting that that perspective as well. John, do you just want to give a final comment before we move on?
Yeah, hi, John Brune again. Just a couple of things. One is to echo the praise around the overall performance, and some of the particularly the mental health and learning disability metrics have been really high profile nationally and regionally, as well as within our local system. And to have such an impressive end of year performance is a testament to everybody that's been involved in that, in both operational and supporting corporate services. It's such a great position to be in. And it's not particularly highlighted in this report, but there's equivalent great performance across all the divisions, and particularly in forensics and community health services, which aren't reflected specifically here, but just to note that it's across the board, and we're clearly not complacent, but it's a good place to be in. And as others have said, to land the money given where we were within year is again, it just highlights the work that's been put in to getting us to this place. The only point I just wanted to make with regard to some of our future planning over the coming year is that I know that people aren't thinking this, but we're not going to move from a COVID to a non-COVID world anytime soon. So in terms of some of our planning and instruction is that we need to start to think about hot, cold and intermediate sites, particularly for our community and inpatient services. So there'll be sites that will be COVID negative, there'll be sites that are COVID positive, there'll be sites that are for cohorting pending results. So some of our previous capacity, if you think particularly around beds, which was one number, will need to increase to accommodate that increasing complexity of our world, and that will need to sort of embed that within our planning going forward, just so that people are aware of that. Thank you.
Thanks very much, John. And if I could just ask Craig, our Trust Secretary, just to make sure that any board members who want access to that full report are able to get that, please. Thank you for that. I think we've explored that, and we can receive that report. Can I just get a check with colleagues if they're happy to receive that integrated performance report? And thank you. In which case, we're going to move on to the CQC Care Quality Commission response and preparation. And Anne-Marie, if you'd like to introduce yourself.
Yeah. Hello, everyone. My name is Anne-Marie Newham. I'm the Executive Director of Nursing, AHPs and Quality. And I'm just going to take you through a little bit about what the CQC are currently doing. So they stopped all of their inspections on the 16th of March. Normally, we would expect the CQC to come in to an organisation that requires improvement on a 1 to 2 yearly basis. So they've issued a guidance to us to say that they wouldn't be coming in their normal way of face-to-face inspections where lots and lots of people come into the organisation. However, they have intimated that they will continue with inspections in a very different format, which is more likely to be desktop exercises, telephone conversations, and they will still want to speak to patients and carers and staff, but in a very different way, possibly by phone. So it was just to say that it's not all stopped. They are still looking at services where they've got a concern. So if I take you to that first section where I've put update on recent CQC inspections. So they came into the Millbrook Mental Health Unit, the Lucy Wade unit, on the 26th of March on the back of something that gave them some concerns. But once they'd been in, they'd seen all the actions that we'd taken and were satisfied with the support that we'd put in place. They lifted all of the conditions that they'd given us and allowed us then to continue to admit patients. We've continued to have internal risk review meetings around Lucy Wade unit, and that's progressed really, really well. John's already mentioned the Ramson Hospital Learning Disabilities inspection. Again, really good feedback on that. And we've had a factual accuracy where we're able to put in anything that we think is not right about the report, but actually we didn't have anything that we wanted to say. So that was really good. They have inspected 5 prison services, HMP services, and again found no breaches of the relevant regulations, which is great. In respect of coronavirus and COVID, the CQC have added COVID-19 as a cause or suspected cause of death, and we're required to report directly to them any cause of death that says COVID either on part 1 or part 2 of the death certificate. The CQC have continued to do Mental Health Act monitoring visits, and they've got an interim methodology there which requires them to continue to seek advice, opinion, and see how we're doing around the Mental Health Act. With regards to freedom to speak up, this is more as important as ever in these times, and they've reiterated with organisations to continue this at pace. And I just wanted to go down then really to say that we're required to do a daily combined report around COVID. And so the Trust is required to ensure that we report on a daily basis. We have a lot of sit reps that we're doing at the moment, and that includes the CQC asking for information that is required. And then also I just wanted to let you know that the CQC published the report it commissioned in 2019 into Walton Hall, and we've looked at all of the recommendations, and the CQC have made some recommendations for all mental health trusts and learning disability services, and we've got those in train. So that was all I wanted to bring your attention to. Also just to say that we have continued to have relationship meetings with the CQC and engagement meetings with the CQC, which are going really, really well. And we are continuing to do some Care Quality Commission progress meetings internally to make sure that we are ready for any inspections that do happen. Thank you.
Great, thank you. And Sue, you'd like to make a comment. If you could introduce yourself, please. Make sure you're unmuted, Sue, as well, please.
Hello, am I working there now? Beg your pardon. And hello, everybody. I'm one of the non-exec directors. It may well be that Julie has a similar comment, as we were talking earlier today, and I was asking about the Ramson inspection. And I think the points that you made, Anna Maria, were about not having any direct breaches of regulations, given the history of all the things that have been under investigation, is really, really good news. And I would wish to say thank you very much to all the staff involved, because clearly my understanding is that the work that the inspectors have seen has been very, very good. They were going in expecting to find something awry and actually found some really, really good stuff. And not to ask for anything further, I think I would like to say well done to all concerned.
Thanks for that, Sue.
Thank you.
Carolyn, can I bring you in, please, for the question?
Thank you, Carolyn White, Non-Exec Director. Anne-Maria, in your report, and you've just referenced it now, the report about Walton Hall, yep. All of the recommendations seem to be things that the CQC need to do, and I just wondered if there's anything specifically that the Trust needs to do in response to that. We did, at the time of that initial concern that was raised nationally, do an internal review. But I just wonder if you are anticipating any specific recommendations for providers.
To be honest, we've turned these recommendations for the CQC into what the provider would then need to evidence. Evidence,
okay.
Yeah, so what we've just done is we've taken the CQC recommendations, we've turned them around and said, right, what is it that they would expect to see from us? So those are the things that we've had to put into place. But ITI produced a report, I don't know what date it came through, but certainly that was the recommendations plus what we had put into place and the actions we'd taken.
Okay, and where will we be picking those up, Anne-Maria? Will that be through Quality Committee or through mental health legislation? I don't, being fairly new to the organisation, I'm not sure where it went before, but I would say that it needed to come through the Quality Committee. Okay, thank you.
We'll make sure that gets tracked appropriately and put into the forward agenda, so that we're doing that follow through.
Yeah.
Okay, I think in terms of that update on CQC, it does tell us that the work that contributes to quality improvement is absolutely continuing, and that's really important in the midst of COVID, even though there's so much activity that is obviously focused elsewhere. So thank you for the update, Anne-Maria. And if we could move on to item 62, the use of confinement in Ramson Hospital, and invite Julie Hankin to introduce yourself, please.
Yeah, thank you, Paul. So I'm Julie Hankin, I'm the Interim Executive Director for Forensic Services. So this paper follows directly from a paper we considered at the last board, which set out the possibility that at Ramson, in order to manage difficult situations through COVID, we would potentially look at extending confinement, and we agreed both a set of mitigations and things we would want to consider to make sure that patients were not adversely affected or that was minimised, and also how we would report that through to the board. So the paper sets out the events that happened in terms of Cotswold Ward during the last month, which do fall within that. And as we agreed, I'm bringing it to the board. So Cotswold Ward is one of our personality disorder units. At the time, there were 2 patients who were positive for COVID and therefore being isolated. But the difficulty became not just whether those patients were willing to cooperate with isolation, but also the level of group unsettledness and increasing high risk behaviours on the ward overall. There was a full MDT meeting which considered all possibilities at length and finally agreed that because of the risk not only of ongoing widespread contamination but also concerted indiscipline, that the ward would be placed in confinement. That was agreed by me on that day and briefed to the non-executives and chair on the same day, on the 17th in the afternoon. The way that was done was to use long-term segregation plans, so every patient had an individual plan setting out activities, fresh air availability, etc. for that time period, and additional activity and psychology staff were brought into the ward for those 2 days. The decision was reviewed then on the 20th and all of those plans were stood down on that day except the one that was already in existence prior to that. There was a patient debrief and staff debrief held on that day to run through and no particular issues brought up. But we've also taken it to the ethics group on the 23rd of April and discussed it there at length. One of the things we agreed at the ethics group was that we would hold a learning review, and I'm in the process of arranging that for the 18th of May, and Alison has kindly agreed to join that as a NED member. I think from my point of view as exec director, I feel convinced from what I was involved in and reviewing since that the situation was as described and all other possibilities were considered and would not have been